Hi, I'm Rebecca Caprio, and this is my project for Nursing 348, Evidence-Based Practice Research. The title of my poster is Reducing 30-Day Readmission Rates Using Medication Reconciliation Interventions and Follow-Up Care Guidance. This poster is here to outline and highlight all the interventions that have shown to work in the past that can be implemented to improve 30-day readmission rates. The overall readmission rates for all types of patients, insured and uninsured, is about 14%. For the age group I'm focusing on, which is 65 years and older, is up to 16.1% right now, which is lumping all Medicare patients together, so it's a little different. The average cost of a readmission is higher than an initial admission, about 5% higher, but it does vary depending on what's done, what facility they go to, and what kind of insurance they have. Between 2003 and 2004, it was charted that the annual readmission costs nationwide was $17 billion. That's a lot of money, especially for Medicare patients, which is government money, and it's hard to bring that cost down. So to assist in reducing readmissions, President Obama called for reassessing readmission risks on admission and making sure that we are communicating with the primary care physicians at discharge. I already know that my facility has implemented these things. We do the healthcare proxy right away, or we have the caregiver forms we sign to make sure that when they go home, there's someone also aware of what the plan of care is once the patient is discharged. So my PICO question, my clinical questions were, what can I do to ensure my patients start out right after discharge, and how can I ensure plan compliance after discharge? My population group is elderly patients 65 plus who are inpatients with a discharge diagnosis of CHF, CKD, or COPD. My intervention would be the nurse would schedule a follow-up appointment with the patient's primary physician or consults as necessary within the recommended time frame at discharge, so that we are not just sending our patients home saying, make sure you follow up, good luck, and kind of leave it up to them. I'm comparing this intervention with what we are currently practicing, which is patients who are discharged with no follow-up with their physician, and that is their responsibility once they get home. So my outcome by doing this is hopefully to decrease my facility's 30-day readmission rates by 10%, which would bring it down to 8.3% by June of 2017. So I started my search with 4 popular databases, which you guys will all know: CINAHL Plus, Google Scholar, Nursing Reference Center Plus, and Medline via Ovid. My favorite one was CINAHL because I was able to use as much inclusion criteria as I needed, enough key phrases, key words to narrow it down, and use the exclusion criteria of level of evidence. I got 75 articles back, and going through them, I was able to use 4 of those, and they are good articles. Google Scholar, however, was a little less accurate. I could only use 1 keyword. I could narrow it down by the date, but I did get back 10,000 still. So just the first one that came up was the only one that was relevant to my study. So I did use that one. Nursing Reference Center Plus is great because as a nurse, they're written by nurses for nurses. They're things nurses can do instead of a lot of these medical journals where, we cannot prescribe patients medication. So it's kind of irrelevant to what I can do personally for my patients. So this gave me back 8 articles, which all were somewhat relevant, some not, but I was still able to use 2 of those, and they were a higher level of evidence, which is great. Medline via Ovid I felt was a little unuser-friendly, and I didn't know how to do too much inclusion criteria there, but I did what I could with my keywords. I got 4,806 citations back, and I was only able to find 1 that I could use to support my outcomes. So in the evidence, my first article I was able to cite was the BLE, and that was a big sample of 620. This intervention was one that aimed at my COPD patients, where the patients who utilize inhalers, DUNEBs, breathing treatments during their admission were given multi-doses upon discharge, so they didn't have to wait for their pharmacy to go get an inhaler, that if they needed it right in the car on the way home, they could take an inhaler, or if they needed to go home first, they could take it. So you're already reducing the risk there by making sure that they have the medication they need on hand without having to go to the pharmacy first. There was a 20% readmission rate, but after they did the intervention of giving them their inhalers at discharge, it was down to 8%, which is a big drop. So I thought that was kind of impressive. And at the end of that article, they did include the cost that it saved their hospital $20,000 by implementing this intervention. The one by Bradley, Curry, Horwitz, Sipsma, Wang, Walsh, and Krumholtz was another article I found interesting. A sample size 585, which was hospitals that were participating in a certain program, certain initiatives. So it's not so much of a population of people. The nurses and healthcare workers participating in this initiative would schedule the follow-up appointment for their patients prior to discharge, and their readmission rates improved by almost 20%. Again, that's huge. So the survey at the end showed how easy it is to do this, and how easy it is to implement, and how much it can save both your patient's time, your time, and your facility's monies. So then I went on, I found a Hitch, Parlier, Reed, Galvin, Fagan, and Wilson article. This one was based on 322 patients. They were all diagnosed with either 3 to 5 diagnoses was the criteria, or they had 5 to 9 medications they were supposed to be taking at discharge that were in their medication reconciliation. The intervention for their patients were that the patients were contacted 2 days after discharge, at which time they were required to schedule a follow-up appointment with their primary care physician. And prior to the discharge, however, the pharmacist would complete the medication list at discharge. So currently at my facility, this is something we're not doing. We're just giving them their med recs, saying, okay, it's called into your pharmacy, you can go pick it up. That's something the nurse does. So I think it's important, especially for the pharmacist, to go over medications that these patients are going to be taking at home by themselves without, barcode scanning or anything like that. I think this is a big deal. So utilizing both those interventions, the calling 2 days after and the pharmacist doing the med rec, there was a 62.6% reduction in 30-day readmissions. This is a big one for me. I think this spoke a lot about how our med recs are done at discharge and how much they could be improved upon. Then finally, a Mitchell article was another one that the population was based on hospitals using HCAP surveys. I think majority of hospitals do use these. They did provide discharge instructions for the patient, but it was not done strictly by the nurse. It was first done by the physicians, who would go over it with them. The nurses would go over it with them, or they would do it at the same time, go over the discharge instructions with the patient. That left little room for questions, confusion, miscommunication, anything that could have gone wrong, because sometimes the doctors may put things in wrong, but if you're in the room talking together, things can get brought up and worked out right then and there. Using this intervention, there was a 5 to 10% decrease in 30-day readmission rates after discharge. So the variation in that percentage is because it was either the doctor doing it alone, the nurse doing it alone, or both doctor and nurse at the same time. So that's just the variation there. When it was all both in the room, I think it was at that 10% decrease. So I thought all these articles provided some great information in that, showing me we can implement more, not only one intervention, but 2, 3, maybe even 4 interventions to reduce this rate as far as we could go as possible. 10% was an ideal change, wasn't too drastic, but as you can see in that table, that there are huge decreases in readmission rates with some of these interventions. So my recommendation, based on the following information, was that my Meditech committee team would insert a nursing intervention, the EMR, to include contact with patient and physicians. So it would say, have you called the patient's physician at discharge and notified them? Have you talked to your patient about a follow-up appointment? Did you schedule up a follow-up appointment? Like, these things could not be skipped. So to make sure that your patient is leaving that hospital with a follow-up appointment and they're aware and the physician is aware. Secondly, physicians should complete medication reconciliations, which is also to be reviewed after the physician completes it by the pharmacist. The pharmacist would be the last one to review and change anything to the medication reconciliation prior to the patient's discharge. Also, it would be ideal if one dose of daily medications to be given to the patient at discharge to ensure medication compliance. There's been so many times where patients have left and they went straight home, said, I'll go to pharmacy tomorrow. By the time they get to pharmacy the next day, they don't take their pills till the afternoon, and they say, well, maybe I'll wait for the next day, and 2 or 3 days could go by before they're taking their medications again like they should. By giving them one dose, daily dose of their medications, we can ensure they're going home and taking their medications for at least 24 hours correctly after discharge. The third intervention would be for nurses to review all discharge instructions once the physicians and pharmacy have reviewed the plan. So once everything is done, physician's done talking with the patient, a pharmacist is done reviewing, the nurse would then be allowed to go in there and review all the information with the patient, making sure it's accurate, completed, ready to go in the folder, and the patient is ready to go. Also, at that time, it would be another ideal to reduce this rate of having someone from the hospital follow up 2 days after with their HCAP scores and just ask briefly if they followed up with their primary care physician yet and when they are planning to do that. I thought there was enough evidence here to point out that there are definitely interventions that do work to reduce readmission rates. It's important to follow up what's right with your facility and your team, but also to go with this research and say this has proven to work, which I think many of these articles have shown. In the end, in June, it's my hope and wish too, when we reevaluate this, that it was easy for the nurses, easy for the physicians, easy for doctors to complete all these interventions. It doesn't take too much time, but it will save money, it'll save time, it'll save our patients from a lot of unnecessary admissions they could avoid if we just do our discharges correctly at the time. So I think I'll follow up with surveys from the patients, from the physicians, from pharmacists, and nurses on how well this is working. Hopefully go up higher in the ladder, see if it's costing anything extra. Hopefully it's not costing anything extra at all, just a change in the electronic medical record system to make sure this gets done correctly and make sure the patients are being safe when they are discharged.